Buenas noches, bienvenidos. Debo decirles que hoy día nuestro ponente habla inglés, pero los que quieran oír en inglés tienen toda libertad. Los que quieran la traducción al español deben fijarse en la parte inferior de la pantalla el icono del mundo que dice interpretación. Apretan ahí y les da opciones. Pone Spanish y listo. Dr. Dinkin, good evening.
Buenas noches.
On behalf
Gracias.
of the Peruvian Society of Ophthalmology, we welcome you. It's an honor to have you here as a speaker tonight. Before you start, let me introduce you to the audience. El Dr. Dinkin es un profesor asociado de Nueva York, del Cornell. Él es director del programa de Neurooftalmología y el director del programa del Fellowship de Neurooftalmología. También es profesor asociado del Departamento de Neurología y del Departamento de Oftalmología. El doctor estudió en Harvard y luego hizo la residencia de neurología en el New York Presbyterian Hospital y la Fellowship de Neurooftalmología en el Massachusetts Eye and Ear Infirmary en Boston. Él tiene varios intereses de investigación, como la hipertensión intracraniana idiopática, la estenosis venosa y la degeneración retrógrada transináptica. Él es miembro activo de la Sociedad Norteamericana de Neurooftalmología y también es miembro del comité editor del Journal de Neuroophthalmology. Él tiene diversos premios, tanto en la parte clínica como en la enseñanza, y él es ponente en diversos eventos nacionales e internacionales. Con ustedes el doctor Dinkin, que nos va a hablar sobre complicaciones neurooftalmológicas en el COVID-19, un tema muy actual. Dr. Dinkin, you can share your computer now.
Thank you so much. Gracias. It is such a pleasure and joy to be with all of you tonight. I wonder, do I need to pause for translation or should I just continue on?
Yes, continue. People is going to choose if they want to have translation or not.
Okay. I was just going to say one of the silver linings of this pandemic era is the ease in which we as doctors have been able to get together to learn together and meet. And so I'm just so happy to be able to meet all of you and to discuss tonight a topic that sort of was hoisted on all of us, I suppose, over the last year and a half. And for me, as a neuro-ophthalmologist at Cornell in New York, the neuro-ophthalmological complications of COVID-19 became something that I was interested in this year. Thank God, things, at least in the United States, are starting to get better, and I hope that this talk is more a part of history soon than it is about our future. But I fear that for all of us, including in Peru and the United States, COVID-19 is to some degree going to be a part of part of the palette of diseases that we see, even in the future. And so recognizing how it can affect vision and the eyes and the brain will remain an important topic for all of us. And so I'll continue on here. Let's see. I have no relevant financial conflicts related to this topic. So I think everyone by now is quite familiar with SARS-CoV-2, which of course is a member of an RNA virus, and of course emerged from Wuhan in China back in December of 2019 and led to this pandemic that is still raging throughout the world, in some countries more than others. And I placed here on the screen some examples of other coronaviruses that cause the common cold, but also some that will cause other important diseases like SARS and MERS, the Middle Eastern respiratory syndrome that emerged in 2012. On the upper right side of the screen, you can see a kind of family tree of coronaviruses and that tells you where MERS and SARS fit in. And at the top, you can see the basic structure of the virus of the spike protein from Nature in 2020, and how that spike protein allows the virus to link up with the ACE2 receptor on cells, which allows it to enter the cells. The close-up is on top, and in the bottom is a cartoon that shows the three parts of the S1 and then the S2 that make up the spike protein, and you see it there linking with ACE2. So in the first half here, I'm going to discuss the efferent complications that might occur in association with COVID-19 disease. And the caveat that I'll really begin the whole talk with is that every observation that I'll review today, most of these observations are based on case series or case reports, or in some cases, observational studies of patients with COVID-19. But in general, it's hard to know if all of these conditions that we will discuss today are in fact related to COVID-19. Some of these observations may have been coincidental. After all, when so many people in society are getting an infectious disease, many of them just coincidentally are going to have other diseases at the same time that may not have to do with COVID. So keeping that in mind as we proceed in the back of our minds. So I'll begin with a case. And this was March 25th, 2020. It was just a few weeks into the pandemic in New York. Our first case was on March 1st, when a 71-year-old woman walked into our clinic. She had well-controlled hypertension, and her chief complaint was horizontal binocular diplopia for 2 days. The resident in ophthalmology called me and said, I think it's probably a microvascular sixth nerve palsy. But looking at the screening form, she did admit to having a cough for the last few days. And in fact, when we tested her temperature, she was 39.3, so she had a fever. And in that given day, when COVID-19 was raging in our city, we suspected that she had COVID-19, sent her to the emergency room where she was positive for the swab PCR. However, before we did that, I did a very brief neuro-ophthalmological exam, which you can see here. The afferent examination was normal. There was no disc edema, but you can see a right sixth nerve palsy here with an abduction defect of the right eye. In the hospital, she did pretty well. Her saturation was only 88% on room air, and she had a lot of blood tests that showed a very inflammatory state, including a D-dimer of over 2,000. And she had extensive pneumonia in both lungs, left more than right. However, she did well from a COVID point of view and left the hospital a few days later. Not before we acquired an MRI of the brain and orbits, however. And you can see here on this MRI that there was enhancement around both optic nerves, but especially around the right optic nerve, consistent with an optic perineuritis, and also around Tenon's capsule, which you can see here in the middle picture on axial MRI, T1 post. And you can see the perineuritic enhancement well on the coronal imaging on the right side of your screen. This was interesting because we didn't see enhancement of the sixth nerve, but it's very hard to see enhancement of the sixth nerve. It's a very small nerve, and you might not see disease of the sixth nerve. But we looked at this as a marker of some kind of breakdown of the blood-brain barrier within the space around the optic nerve, which of course is a CSF space, cerebrospinal fluid, bathes the optic nerve. And we looked at this as either inflammation around the optic nerve in the orbit and potentially in the spinal fluid as well. And we thought, well, what is the differential diagnosis? Perhaps this patient had COVID-19 and the stress of the infection led her to have a run-of-the-mill microvascular sixth nerve palsy, just provoked it. Perhaps the hypercoagulability of COVID-19 led to a small ischemic microvascular sixth nerve palsy. We also considered that it might be post-infectious autoimmune sixth nerve palsy, especially given this inflammation. Yet it was so concurrent with the infection occurring at the same time which argued against it being post-infectious. And then we considered a direct neurotropic viral infection affecting the abducens nerve. And we settled on that as the most likely diagnosis simply because of the timing of it and because of the MRI findings that we felt were a marker of a reaction to the virus in the CNS, in the central nervous system. How could the virus get into the abducens nerve and get into the central nervous system, though? Well, of course, like many viruses, hematogenous spread was considered. We also thought about perhaps getting through the choroid plexus. Turns out that the choroid plexus has a high preponderance of ACE2 receptors on cells of the choroid plexus, which might allow the virus to enter those cells, and from there as a conduit into the nervous system or perhaps the spinal fluid. The meninges also have ACE2 receptors. And we thought also about the olfactory nerve. As you know, anosmia is a common symptom in COVID-19 patients. And while that anosmia and dysgeusia tend to be attributed to infection of the olfactory epithelium, in some cases you see involvement of the olfactory nerves as well, such as in this paper by Strauss and colleagues on the bottom right, where you see a hyperintensity of the olfactory nerves in a patient with COVID-19. And this kind of thing has been presented in many papers. Although the olfactory nerves don't appear to have a high level of ACE2 receptors, in some cases it appears that the virus can affect those nerves, which might lead to more long-term anosmia. And of course, from there, that could be a conduit into the brain, especially the frontal lobe. So the patient returned at 6 weeks, and I had a little video visit with her. And you can see that here. And you can see that at that time, the abducens nerve was still present. And this was a nice example of how we were following a lot of our patients early on in the pandemic through telemedicine. And as I'm sure you did, we figured out ways to examine patients remotely. So fortunately, this patient's husband was a willing participant as a neuro-ophthalmologist and helped me perform the cross-cover test, which I'll show you right here.
Cover the, look, yeah, there you go. Cover the right, find that camera, cover the right. There you go, cover the left. Wonderful.
And while I couldn't examine that with prism bars, of course, through telemedicine, at least it could give me a qualitative sense of the residual abducency.
Cover the
So let's zoom out for a minute and talk about the neurological complications of COVID-19 and what we knew at that time. Really, the only paper we had at that moment in time was a retrospective review of 214 patients from Wuhan. And in fact, at that time, it wasn't really published yet. It was just in pre-published state. But now it has since been published in JAMA Neurology. And as you can see, 36.5% of patients had some neurological symptoms, mostly headache and dizziness, which are not specific to invasion of the central nervous system. But 5.7% of severe cases and nearly 3% of all cases presented with acute cerebrovascular disease like stroke. Interestingly, 1.4% reported an impairment of vision, although this paper was not clear about what that impairment was, whether it was double vision like our patient or loss of vision. It's interesting, around the same time, a paper in JAMA Ophthalmology reported on the ocular findings in COVID-19 patients, also in China. And they found that nearly a third of patients had ocular manifestations, such as conjunctivitis, conjunctival hyperemia, chemosis, epiphora, or at least increased secretions, and 5% had conjunctival swabs that were positive for SARS-CoV-2 PCR. So perhaps in our case, the ocular surface served as a conduit to get into the orbit, perhaps even into the peri-optic nerve space and ultimately into the CNS. But such transport into the CNS has really not been proven. Let's zoom out a little bit and look at reports of cranial nerve palsies in COVID-19 patients. For whatever reason, a lot of abducens palsies were reported early on in the pandemic, including our case here in the upper left in neurology, We reported 2 more cases later on that we saw, along with some friends of ours at NYU. But then ocular motor nerve palsies were also reported, and even a 4th nerve palsy, bilateral, had been reported in the setting of what looked like a cerebral vasculitis, affecting, you can see here, the vertebral artery in the bottom right part of your screen in the setting of infection. But most of the cases had no radiological features, and so our case was a little bit unique in that sense. Pretty much all of these cases, the cranial nerve palsy occurred within 3 days of the fever and cough, supporting a connection with the infection. Although, again, some of them might have been coincidental. Interestingly, just a few days after our first case, the neurologist with whom I shared that case called me up and said, "We've got another one." And indeed, another patient came in with double vision in the setting of COVID-19. This was a 36-year-old man. He actually had a history of congenital strabismus, who presented with a new left ptosis and diplopia and bilateral distal leg paresthesias. He also had subjective fever, cough, and myalgias for 4 days. And on exam, he had hyporeflexia and loss of sensation. He also had a profound gait ataxia. And so we examined this patient. And as you can see here, his pupil on the left is a little bit larger than the right. It wasn't as evident here, but the next day he developed a more severe left ptosis. He also has left eye adduction limitation, which you can see here, left eye infraduction limitation. And so all of that together was consistent with a partial left third nerve palsy, mostly the inferior branch. However, there was also some limitation of abduction in the left eye. And so while it was hard to rule out some contribution to this exam from the gentleman's congenital strabismus, it was clear from his presentation that the ptosis, the mydriasis, and in fact the diplopia were all totally new findings. Of course, the ataxia was new, and all of the sensory findings were new as well. We performed an MRI, which showed enlargement and enhancement of the third nerve. You can see a T2 hyperintensity of the third nerve, inferior branch on all of these images. And on the coronal imaging, you can see how enlarged it is as well. So his course, he did very well. His nasal swab was positive for COVID-19, but he never had a pneumonia. Like I said, on the second day, his eye movements worsened, his ptosis worsened. He actually lost full abduction in the right eye, which had been okay in the first day. So what is this disease? You may already know what this disease is, but we didn't think it was direct cranial nerve invasion this time, in part because there seemed to be more than one cranial nerve involved, and because of the ataxia, the areflexia, and progressive ophthalmoplegia. Together, you're probably thinking what I'm thinking, which is that he had the Miller-Fischer syndrome, it possibly related to his COVID-19. As you know, Miller-Fischer syndrome is a type of Guillain-Barré syndrome where you get a polyneuropathy, but unlike Guillain-Barré, motor nerves are not affected. Instead, sensory nerves are affected, so one gets ataxia and areflexia, and cranial nerves that move the eyes are affected, yielding the ophthalmoplegia. His ganglioside panel was negative, however, often it's positive. And that's the original 1950s article by Miller-Fischer himself describing the first case of Miller-Fischer syndrome. And at the time that we saw this patient, Guillain-Barré had already been reported after COVID-19. Interestingly, in that case that you see here, the cough and fever actually developed after the Guillain-Barré. And that means that maybe the patient caught COVID while they were in the hospital for Guillain-Barré. However, the fact that when that patient was admitted, they already had lymphopenia and thrombocytopenia, which are features sometimes of COVID-19 infection, suggested that they were already infected and that the Guillain-Barré was therefore a post-infectious complication. Miller-Fischer had just been reported when we saw our case by Gutierrez Ortiz and colleagues from Spain. And they actually had two cases. And And in the first case, unlike most cases of Miller-Fischer that are associated with an antibody against GQ1B ganglioside, theirs was associated with GD1B, which was I found very interesting. They didn't check an antibody in the second, but they did look for SARS-CoV-2 PCR in the spinal fluid, and it was negative. Again, consistent with it being a post-infectious disease, as we know Miller-Fischer to be, or at least para-infectious. And since then, in the literature, has been flush with many Miller-Fischer cases in the setting of COVID-19. Although, interestingly, most of them, the antibodies have not been positive to the ganglioside, suggesting that perhaps it's a different kind of nerve molecule that is confused in Miller-Fischer syndrome. This was a different patient, who, just changing subjects for a moment, who was 68 years old and presented to me also, this time not with double vision, but with ptosis. He had a history of atrial fibrillation and high blood pressure, and had been hospitalized with a very severe COVID-19 for 7 weeks, was released in June of 2020. And a few weeks later, he presented to me with bilateral ptosis, which was okay in the morning, but worsened with sustained upgaze. He also had an esophoria. On exam, he had curtaining, so when I lifted one lid, the other came down. He had a Kogan lid twitch after prolonged upgaze, and with an ice pack placed on his lids, his ptosis improved greatly. This led me to suspect myasthenia gravis, and of course, his receptor antibodies for binding and modulating were both elevated. And so this was a case of ocular myasthenia that followed a severe COVID-19 infection by a few weeks. Again, suggesting that this was a post-COVID-19 complication. Since then, many cases that are similar to my own have been reported. You can see here 8 cases. Restivo and colleagues had 3 of them. And interestingly, here, most patients did have antibodies, mostly acetylcholine, but the last 2 cases in the literature were to the MuSK antigen. And it's interesting, myasthenia is a tough condition already with COVID-19, because COVID-19 can lead to myasthenic crises because of the both the inflammation and inflammatory response and pulmonary involvement. And hydroxychloroquine, which had been used in the past, although not so much now, but early in the pandemic for COVID-19, can aggravate myasthenia. Okay, so this was another really interesting case I saw in April 2020, a 56-year-old man who had a history of Duane syndrome, who presented with headaches and worse with eye movements, and developed transient vision loss, whiteouts of his vision in his right eye, lasting from 3 to 15 minutes each. Interestingly, he would have a relative afferent pupillary defect only during his episodes of vision loss. But the relative afferent pupillary defect would go away afterwards. We thought, well, boy, could this be stroke? But a stroke imaging was all negative. We thought, could he be having intermittent angle closure? But his angles were fine. And so he ultimately underwent imaging of the orbits. And you can see here, similar to my very first patient I showed you with the abducens palsy, he had a perineuritic enhancing pattern around his optic nerve. And we felt that this inflammation, potentially associated with his COVID-19 infection, was leading to a reduction of blood flow and with changes in blood pressure, transient ischemia. This was interesting because this was April 20th. The virus had been with us for about 5 weeks or so to any real degree. And by the time we tested him, his antibodies were positive, but his PCR was negative, suggesting that he had had COVID-19 a few weeks before. Couldn't have been that much before, since the pandemic had really just started. And again, a connection suspected, but not 100%. I'm going to switch gears now from cranial nerves and neuromuscular junction and orbit to the central nervous system in a case that also affected eye movements. This case was generously shared with me by the wonderful neuro-ophthalmologist Janet Rucker at NYU, who saw this patient who had a severe case of COVID-19 and had involuntary horizontal conjugate deviation of the eyes. In the first video, you can see that the eyes were forcefully deviated to the right, which you can see here. Even as they were asked to look to the left, they couldn't. But then later on, they were stuck looking to the left, to the left. And then they went back to the middle here in this third video, and then developed a little bit of nystagmus. So this phenomenon is known as periodic alternate gaze deviation. And this can happen in cerebellar disease and brainstem disease. Generally, the direction alternates every 1 to 2 minutes. It's similar to periodic alternating nystagmus, or PAN, in which spontaneous horizontal nystagmus occurs, which you've probably heard of, a condition that responds well to baclofen. But in this case, you can see the neuroimaging, and you can see very symmetric hyperintensity in the dentate nuclei of the cerebellum in this patient. By the way, this kind of pattern is consistent with a necrotic encephalopathy, an acute necrotic encephalopathy, sometimes with hemorrhages. And you can also see in this patient involvement of the occipital cortex. If you look very carefully at the flare, there's hyperintensities within the sulci in the bilateral occipital lobes. And necrotic encephalopathy is felt to result from an intracranial cytokine storm, and prior to COVID-19 was reported after influenza infections and other viral infections. So this case that was shared with me suggested that it can occur sometimes after COVID-19. Here is another case that had no neuro-ophthalmic features that I knew of, but is very striking, that involved both thalami in the setting of COVID-19. And you can see on the bottom picture, which is called a susceptibility weighted imaging, where hemorrhage is dark. You can see a lot of hemorrhage within the thalami in that case, hence the name hemorrhagic necrotic encephalopathy. Pupillary problems have been described in COVID-19. I saw a 51-year-old woman who had COVID-19 in November 2020 and was enrolled in a trial of monoclonal antibodies, but the screening for the trial, as she had COVID-19, found that she had severe anisocoria, which she had never noticed before. And she was sent to me. I found no pupillary rough in the larger eye, sectoral paresis, and pilocarpine reversed the anisocoria, all consistent, and that was dilute pilocarpine, all consistent with an 80s pupil. Interestingly, in the literature, there had already been 2 prior cases of 80s pupil in association with COVID-19, one 2 days after and one that was 11 days after. In our case, it seemed to be at the same time as the COVID-19, suggesting that perhaps the virus can get into the ciliary body, which, as we know, is the location of neuronal loss in cases of 80s pupil. Okay, now we're going to switch gears and look at afferent complications, vision loss from COVID-19. Far and above, probably the most likely cause of vision loss in patients with COVID-19 is homonymous hemianopia. This was a 61-year-old man I saw with a history of multiple myeloma, hospitalized March 22nd, 2020 with fever, cough, found to have COVID-19, treated and ended up with a pulseless arrest, had atrial fibrillation. And when he woke up, he was noted to have a left gaze preference and a right temporal occipital infarction, which you can see here. And when I saw him in the office, he had a clear left homonymous incongruous hemianopia with some sparing paracentrally in the right eye. Not surprising given the location of that stroke. And as we mentioned earlier, in hospitalized patients like this patient, stroke occurs in nearly 6% of these patients. And this gentleman was no exception. A lot of other cases of homonymous hemianopsia have been well described in the literature, including this case by Bodier and colleagues published in the Journal of Neuro-Ophthalmology, where there was also serpiginous enhancement. And in that case, there was bilateral involvement. You can see a little bit in the right occipital lobe too, leading to bilateral visual field loss. And that case was interesting because it also was complicated by alexia with agraphia, which can occur if you involve the pure word form location in the left temporal occipital lobe. So this was one of those rare cases where a lesion right in that spot led to a pure word form alexia. Even more severely was this paper by Sear and colleagues, where they presented two patients who unfortunately had bilateral vision loss from bilateral occipital infarction. But there are other mechanisms by which COVID-19 can cause homonymous vision loss. And one of the most prominent ones is PRESS. PRESS is posterior reversible leukoencephalopathy syndrome, of course, which generally occurs in the setting of high blood pressure or renal failure and certain medications. But this was a case that we had seen in the hospital with vision loss related to PRESS in the setting of COVID-19. But here you can see a nice article by Gosh and colleagues where they describe somebody who had hallucinatory palinopsia. So they would, whenever they would see something going by, there would be a trail of images due to their occipital PRESS. So just like any other cortical disease, COVID-19 related infarctions or PRESS can result in higher cortical visual problems, alexia, palinopsia, and others. This was a nice larger study by Eaton and colleagues where they looked at cortical findings in COVID-19 and on neuroimaging, that is. And basically 14% of the 2,000 patients had neuroimaging. And of those, 21% had acute or subacute findings. 11% of them had infarction, and 3.6 had hematoma, so some have hemorrhage. Only 1.1% actually had PRESS. And a small portion actually had MRI, probably just a reflection of the sick nature of many of these patients. And half of them had findings, 6 of whom had cranial nerve findings. And interestingly, of those with cranial nerve findings, 4 of them had hyperintensity of their olfactory bulb, again, suggesting an entree into the nervous system through the olfactory nerves. Now, moving away from the cortex, what about the optic nerves? I showed you a few cases where there was enhancement around the optic nerves, but not really within the optic nerves themselves. Well, this was a nice case shared with me by a terrific neuro-ophthalmologist in California named Vivek Patel, who found a 26-year-old man with bilateral eye pain and vision loss in the setting of Coffin myalgias and had severe vision loss, hand motions in the right eye, 20/50 in the left, in the setting of PCR positive SARS-CoV-2, and on exam had bilateral disc edema and with a little bit of venous congestion and a few little retinal hemorrhages. And you can see the OCT confirming the high retinal nerve fiber layer thicknesses. His MRI showed, interestingly, enhancement of both optic nerves, and especially around the right optic nerve, another kind of perineural pattern, but within the nerves themselves. He was treated with intravenous steroids, as is the tradition for optic neuritis, based on the optic neuritis treatment trial, in order to speed up improvement of vision. And in so doing, the vision did improve to 20/50 and 20/40. And myelitis was also seen that was asymptomatic on MRI of the spine. And a spinal tap, lumbar puncture, showed a pleocytosis, white count of 55, with no CoV-2 PCR in the spinal fluid. And his myelin oligodendrocyte glycoprotein came back positive. So this was a case of MOG positive neuromyelitis optica spectrum in the setting of COVID-19. And it was published last year in the Journal of Neuro-Ophthalmology. But since then, many other cases of optic neuritis in the setting of COVID-19 have been reported. Another MOG positive one here by Sawalhe and colleagues. Another MOG one here with avid enhancement of both nerves by de Rougeter and colleagues. Another one that seemed to be associated with multiple sclerosis and unilaterally. And then another one that was associated with panuveitis and vitritis and papillitis. So really a kind of different category there in the bottom right. So here again, this is most likely a para-infectious phenomenon where exposure to this novel antigen or many novel antigens, basically provokes some kind of molecular mimicry and ultimately leads to a MOG-positive optic neuritis. Whether these patients would have gone on to have MOG anyway is unclear, but I suspect maybe they would have, and that this just kind of provoked their first episode. Okay, this was an interesting case that I saw of a young woman with new floaters, she said. She was a 20-year-old woman. I saw her on March 2nd, which was right before the pandemic in New York. And she had pulsatile tinnitus for 3 years, hearing her pulse. No visual changes. And on exam, she had no papillodema. But as you can see on MRI, she had an empty cella and she had severe venous stenosis in her one dominant vein. And I said to her, I think you probably have idiopathic intracranial hypertension, even though you don't have papillodema. Your MRI supports it and you have a common symptom of it. And I recommended a lumbar puncture, which she refused. But then I recommended weight loss and a little bit of acetazolamide to reduce the intracranial pressure, which I felt would get rid of her tinnitus. She started the acetazolamide, but her headaches worsened and she came back to my clinic. And she said, I don't know why I'm getting so much worse. And she developed a cough and fever and anosmia. And she came in and now she developed these new floaters, she called them, in both eyes. But when you spoke to her, her floaters were actually enlarged blind spots in both eyes. And you can see here on exam, very much enlarged blind spots. She had grade 3 papillodema, grade 4 papillodema in both eyes, where there was loss of veins and arteries on the discs themselves, and actually ended up being resistant to higher and higher doses of acetazolamide. And we ended up having to treat her surgically with a venous stent, which led to recovery of her papillodema and her vision loss. Vision loss in the left eye was pretty significant because it extended all the way to her central vision, as you can see here on the left. And a follow-up MRI during the period in which she had COVID-19 showed that her venous stenosis worsened, but she did not have thrombosis. So this was really interesting. She clearly already had idiopathic intracranial hypertension, but a very mild form of it without papillodema. But when she got COVID-19, her disease took off and she ended up with severe medically refractory papillodema. So we wondered why COVID-19 really brought her IIH out of the woodworks. And we think probably the general inflammatory state of COVID-19 may have led to meningeal thickening, although we didn't see any on the MRI. You might wonder, did she gain weight because of quarantine? But quarantine really hadn't started yet, and she hadn't gained any weight. Maybe the hypercoagulability of COVID-19 could have led to dural venous sinus thrombosis. And even though her MRV didn't show thrombosis, perhaps there was some sludging of venous blood because of hypercoagulability. And finally, as I mentioned earlier, choroid plexus dysregulation due to SARS-CoV-2 was theorized. And we're not the only people who have reported greater numbers of IH in the setting of the pandemic. Thaler and colleagues took a look at this and found that during the height of the lockdown in Britain, they had some cases of secondary causes of raised intracranial pressure, 2 from venous sinus thrombosis, and 1 case of IIH in the setting of COVID-19. And others like Silva and colleagues have reported the confluence of these 2 diseases as well. Actually, they looked at people who had lumbar puncture who also had COVID-19, and they found that in 6 of them, the opening pressure was greater than 25 centimeters of water, but only 2 of them actually had papillodema. So really the story here needs to be elucidated. Whether or not IIH is really has any association with COVID-19 remains to be seen, but certainly in some rare cases, it may provoke it. This, however, has a little more data for it, and this is the pediatric multisystem inflammatory disorder, PMIS, which, as you may know, is a disorder that's in children after COVID-19, where they develop usually a rash, diarrhea, and shortness of breath and chest pain, and can ultimately enter hypotensive septic shock, or what looks like sepsis, very much like Kawasaki's, a severe form of Kawasaki's disease. And so I saw a patient in April of 2020 who had this multisystem inflammatory disorder after COVID-19. Unfortunately, he almost died from basically hypotension and shock, but was revived. But interestingly, it was noted to have an expected rash, including a periorbital rash, which is not seen that often, even in MIS. But interestingly, as he was recovering from his sepsis and everything else, septic shock rather, he started to get really bad headaches and blurry vision, and binocular double vision. You can see here, by the time we saw him 2 weeks later in clinic, his papillodema that they had seen in the hospital was already coming down and quite mild, with only slight visual field defects. And by a few weeks later, it had come down to really resolved. And you can see the OCT numbers to demonstrate that. And his abducens palsies resolved as well. He had a very high antibody titer, indicating a robust inflammatory reaction to COVID-19. Just as we were seeing this patient, a few weeks later, Vercouli and colleagues reported a similar case of pseudotumor cerebri syndrome associated with this MISC condition in a child. And since then, there have been several more cases, 6 more cases reported in the literature. None of us really understand why MIS causes, in some rare cases, high intracranial pressure, but all the same mechanisms that I discussed in terms of IIH with COVID-19 could be at play. Retinal findings have been described in some patients with COVID-19. This was one of my patients that had, unfortunately, bilateral vision loss from COVID-19 and had bilateral large occipital infarcts, but also had effects of ischemia in his retina. You can see here cotton wool spots and hemorrhages. And Marino and colleagues in Lancet had described some findings as well in OCT, although these findings have really been put into question because, as you can see here, these hyperreflective spots within the ganglion cell layer some of them appear to maybe be just blood vessels. Central retinal artery occlusion also been reported with COVID-19, probably same mechanisms as lead to cortical infarctions. And this is a nice study, the Serpico study, where they looked at all retinal findings in 54 COVID-19 patients versus 133 unexposed patients, and found a higher number of cotton wool spots. Retinal drusen actually were not higher in those patients, but higher levels of dilated veins, and suggesting that for some of these patients, the retina was affected. This is a little bit confounded, though, by the fact that patients in the hospital for COVID-19 are more likely to have a history of hypertension or diabetes, since that can lead to more severe disease. So we have to be very careful in assessing our patients to really learn what is true causation and what is just confounded association. To summarize everything here, we've got COVID-19 can lead potentially to direct neural invasion, which has been demonstrated radiologically in the olfactory nerves, but not pathologically in many cases, but potentially could be the mechanism for many of our cranial neuropathies that we've seen. Endothelial dysfunction, which is known to occur with COVID-19, is probably one of the causes of PRES, which can lead to homonymous hemianopia and higher order visual problems. And endothelial dysfunction may also lead to cortical stroke, which also may lead to homonymous vision loss. The cytokine storm that's known to happen in COVID-19, perhaps through bradykinin interactions, leads to post-infectious autoimmune disease, which can lead to the acute hemorrhagic necrotic encephalopathy, myasthenia gravis, Guillain-Barré, Miller-Fisher syndrome, and one topic I didn't talk about today, rhomboencephalitis with nystagmus and opsoclonus. Also, perhaps optic neuritis, especially MOG, that pediatric multisystem inflammatory syndrome, which has since been associated with rare cases of IH and papillodema. Respiratory failure itself can lead to hypoxia and hypoxic ischemic encephalopathy, which can have a whole host of neurological symptoms, including visual. And of course, let's not forget the hypercoagulable state, which can lead to stroke, central retinal artery occlusion, venous sinus thrombosis, which of course can mimic IH and lead to papillodema. In conclusion, SARS-CoV-2 appears to affect the nervous system in a sizable minority of patients, not limited to severe cases. The real primary mechanisms are not known, but probably it's multifactorial mechanisms of reaching the nervous system. And in some cases, it's simply post-infectious. Optimal management for all of these cases is not yet known, but clearly in some cases, anticoagulation has a role, and steroids and perhaps tocilizumab, which blocks IL-6, may have a role in post-infectious disease. I again pray for both of our countries that everything I've talked about today is not needed for any of us in the future, as I hope the pandemic continues to recede around the world. I look forward to all your questions. And again, I'm so grateful for the opportunity to spend some time with you, my colleagues, and here in ophthalmology in Peru. And it's my greatest wish that I one day get to meet you in person and in your country or mine. Thank you.
Sure. Wonderful. Wonderful talk, Dr. Dinking.
Thank you so much.
I have a question. There is a great variety of neuro-ophthalmological manifestations. People is asking me if this patient get better or not really. They improve with the treatment?
Yes, that is a great question. So what I would say is that all of the post-infectious inflammatory conditions that I saw got better. For example, the gentleman with the perineuritic inflammation in his orbit, he got totally better, both clinically and radiologically, with the help of a little steroids.
Yes.
The cases of myasthenia gravis got better within 6 months, which is interesting and argues against chronic myasthenia. The Miller-Fischer patient, I just saw him last week after a year and a half. I hadn't seen him. He came in and he was better, which was wonderful. The cases of optic neuritis got better than I'm aware of, although I'm not certain that the MOG cases didn't go on to get more MOG and require chronic immunosuppression. I just don't think there's enough follow-up to know if they'll recur.
Right.
But of course, stroke is a different story. Those patients who developed homonymous hemianopia or alexia from stroke or cortical vision loss, at least my cases, did not improve beyond a small amount, just as we would expect after stroke.
Sure. Doctor Cáceres tiene una pregunta. Por favor, pueden abrir tu micro. Por favor, señor Manuel, el doctor Cáceres quiere hablar.
Hello, good evening. Thank you for your marvelous talk, Dr. Dinking. This is Javier Cáceres, retina specialist from Hospital Rebagliati here in Lima, Peru. I have a question for you. Have you seen any cases of neuroretinitis related to COVID? Some cases have been described, not, but I don't know if you have seen, or you may think that neuroretinitis can be related to these kind of patients. And another question, do you do something different for the management of the patients with optic neuritis related to COVID, or just the typical approach you do for a regular patient? Thank you so much.
Thank you. To answer the first question, I have not seen any cases of neuroretinitis following or during COVID-19, but since neuroretinitis often occurs in the setting of infections, including some viral infections and some bacterial infections, in addition to primary inflammatory disease, I wouldn't be surprised if it occurred as a para-infectious phenomenon. And I think if I saw it in the setting of COVID-19, I would treat with corticosteroids to try to minimize any vision loss after ruling out other primary causes. If you have a case of it, I'd love to see it and take a look at it with you and help evaluate it. I'm always interested in these cases. To answer the second question, yes, I would treat optic neuritis even in the setting of COVID-19 with intravenous corticosteroids, certainly if there was a significant degree of vision loss, as there was in Dr. Patel's case, and especially if it was MOG positive or aquaportin 4 positive. As you may know from the optic neuritis treatment trial, the overall outcome of vision loss a year later doesn't really get much affected by whether you treat with IV steroids or not in your typical bread and butter optic neuritis case. But if it's aquaportin 4 positive or MOG positive, it's really, especially aquaportin 4, but MOG as well, you really need to treat with IV steroids. And for that reason alone, I treat every case of optic neuritis with IV steroids unless they're a brittle diabetic or have some other contraindication.
Right. I have another question from Dr. Dolores Rivero from Argentina. Have you seen any neuro complications with vaccination?
Yeah, that's a wonderful question. I haven't seen any yet come in my door. I've certainly heard patients. In fact, I just had a patient today who had a relative who seemed to have had a deep vein thrombosis in their leg after the Moderna vaccine. And it has been reported that cerebral venous sinus thrombosis, of course, has occurred after a COVID-19 vaccination, but very rare, of course. I believe there were, something like 1 in a million in the original study. And as you know, Johnson & Johnson's vaccine was paused for a week or so when that was being elucidated. I haven't seen, post-vaccine Guillain-Barré or Miller-Fischer or myasthenia. I'm sure someone's reported it, and I'd be curious if anyone's aware of it, but I just haven't seen it yet. And, pretty much 90% of the patients that come into my clinic have been vaccinated. Really, even greater numbers of my patients have been vaccinated than had the disease. So I think they're rare, if at all.
Okay, Dr. Diana Rojas is asking if the myasthenia associated with COVID-19 is autoimmune, or
yes.
What is the origin?
I'm fairly certain it's autoimmune, and that's because in our case and the other 8 cases in the literature that I was able to find, acetylcholine receptor antibodies were positive, or MuSK were positive in every case but one, which really suggests that it's autoimmune, that again, some molecular mimicry led to an immune, cytokine storm led to an immune response that ultimately led to a myasthenic flare-up or myasthenia gravis de novo. Because all the cases I showed you were de novo, that these patients had never had myasthenia before. I don't think it's at all the virus somehow directly interacting with the neuromuscular junction or anything like that. It's really autoimmune, and therefore it should be treated, I think, certainly in severe cases or moderate cases with the way we would normally treat myasthenia, which is corticosteroids, if needed, IVIG or plasmapheresis, etc.
Okay, Dr. Amelia Serrate, very prestigious doctor here in Peru, tells us that she has seen central retinal vein obstruction and rubiosis in some cases.
Yes. Thank you for sharing that. I did see one central retinal vein occlusion in the setting of COVID-19 myself, and I think that makes a whole lot of sense. We know hypercoagulable state, especially in the venous system. I try not to include too many retinal findings in my talk, but they're out there. And I don't know, how did yours do? How did you treat them?
Doctora Serrate, ¿cómo se trató esta obstrucción de la vena central? Doctora. Por favor, señor Manuel, el micrófono de la doctora. Doctora Serrate. I don't think she's there. Something happened.
That's okay. Anyway, please thank her for the question.
Sure.
Appreciate it.
Sure. ¿Alguna otra pregunta? Alfonso, ¿tenemos alguna pregunta del YouTube? Creo que no. ¿Hay algún comentario? ¿Alguna experiencia que quieran compartir con el doctor? Pues no, I think... ¿alguien quiere hacer un comentario, doctor Vargas?
Ophthalmic, oh, an ophthalmic artery occlusion, it looks like, huh? Is that OACR, I think? Is that ophthalmic?
No, it's a vein. Vein.
The vein, okay. Yeah, I'm really curious to hear what all of you have seen. You know, we all have our own stories. Yeah, that sounds like Dr. Cardenas has seen an ophthalmic artery. Wow, that's,
Interesting.
You know, again, were you able to treat with, you know, intraarterial TPA or anything like that?
Let me ask, por favor, señor Manuel, ¿podría darle el micrófono a la doctora Serrate? Dice que no puede abrir, quiere intervenir. Señor Manuel.
Sí, doctora, diga.
Por favor, ¿le podría dar el pase a la doctora Amelia Serrate para que quiera intervenir, para activar su audio?
Listo, ya está.
Doctora, adelante.
Buenas noches, doctora. Doctor, buenas noches. Linda la charla, muy clara. Mi experiencia es que yo he visto en un médico obstrucción de la vena central de la retina. Después de 2 meses de COVID con internamiento en UCI. Y lo que me llamó la atención es que tenía una visión de 20%, pero tenía abundante rubiosis a nivel del iris. Y una presión elevada. O sea, ya llegaba él por hipertensión ocular secundaria a rubiosis. ¿Qué me puede comentar el doctor acerca de esto?
Doctora, él quería saber qué tratamiento recibió ese paciente, si tuvo alguno. No sé si usted tiene ese dato. Él no había visto un caso así hasta ahora y le agrada mucho la colaboración suya. Y quería saber qué tratamiento tenía.
El tratamiento fue el que le dieron en UCI por el COVID. Nosotros lo que hicimos fue disminuir la presión, bajar la presión, tratar el problema de la rubiosis con antiangiogénicos y luego está en programación para hacerle cirugía con válvula.
Dr. Dinke, did you hear Dr. Serrate?
Oh, I heard. I wish I understood better, though.
Oh, I see. Oh, she told me that she told us that the patient was a doctor who had the symptoms 2 months after the infection, the respiratory infection. He was having high intraocular pressure, rubiosis iridis, and central retinal vein occlusion. The treatment was to decrease the pressure, and the anticoagulant treatment was done in the UC by the doctor who was treating the general case.
Wow. Thank you so much for the details. Really fascinating. Yeah, thank you.
Dr. Samayoa is asking if in the case of a fourth and sixth nerve palsy, which treatments did the patient have?
Yeah. In our case of the sixth nerve palsy, the first case I saw of any complication, actually, it was early in the pandemic, and so hydroxychloroquine was used in that patient. And I believe that was it, because he otherwise looked great. He did not require corticosteroids, nor did he get, and they didn't have monoclonal antibodies yet. And they were just starting to work on convalescent serum. So he just got hydroxychloroquine and was sent home 2 days later. Some of the other cases in the literature, though, were also treated with corticosteroids. And in some, they were also given antibiotics along with the corticosteroids and along with the hydroxychloroquine. None of my patients that had these neuro-ophthalmic complications required monoclonal antibodies or remdesivir. But of course, I've seen many COVID patients in my time in the hospital, and in New York for a long time, we were giving remdesivir along with corticosteroids for more severe cases.
And they get better with the remdesivir?
Yeah,
We don't
the
have
data,
that here.
Okay.
We
Yeah,
don't use it. We don't know.
the data is not wonderful for it, but yeah, I think it's better than not using it at all in cases that are hospitalized. As certainly corticosteroids, of course, has a lot of data for it in patients with pulmonary disease. And of course, there's some data for monoclonal antibodies, but none really that I've been convinced of for hydroxychloroquine. But I'm curious, how have you been treating patients in Peru? And are you still seeing patients with COVID-19 these days?
Yes, a lot. We had the vaccination started just in February.
I see. Yeah.
Well, we had a very, very bad numbers. Yeah,
I'm
we
so
do see
sorry.
those patients. Yes, that's something. Well, I have
Yeah,
a case. Dr. Cardenas is saying that he saw a central retina artery occlusion. He had a case of that.
Wow. That's
Dr. Cardenas,
incredible.
you want to explain the case you saw?
Well, yes, I saw the patient, but he was
Está muy bajo tu volumen, se oye poco.
Hello?
Sí.
Hello.
Hello, do you hear me? Hello?
Sí.
Okay. Okay, this patient was a hospital worker. He was in the intensive unit for about 2 months. And after the 2 months, he woke up. He said he couldn't see for one eye. When we checked him, he was just an artery occlusion, but in the atrophy state. So we couldn't do anything else.
Mm.
It was a light perception vision.
Mm.
Mm.
How fascinating. If any of you, I encourage everyone to, publish their cases if they're interested, because the more that's out there, the more we can try to sort all of this out.
Sure.
And if any of you want, I'm working on a review of this, a review paper, and if you want to send me a case to include with your name to acknowledge it, always happy to do that as well.
Oh, that will be wonderful. We'll contact you.
Yes,
Sure,
I have
absolutely.
I have the fundus photo on the OCT of that patient.
Wow.
Yes.
Great.
Yeah, that would be a great kindness of you, because people should see these things and know what the possibilities are, because even though we don't really know causation yet, I think it's important that when we as ophthalmologists, we see a patient with CRAO who doesn't have risk factors otherwise, hypertension, diabetes, we should think about, hey, maybe this is an occult case of COVID-19. and vice versa. And someone with COVID-19 who has visual changes, obviously we should consider all of these known complications.
Right. Dr. Cáceres, ¿quiere intervenir?
Yes, thank you. A few minutes ago, you said something like you are performing a TPA injection for CRVOs. Is that something done regularly at your center? I don't think
No.
we don't do that anymore. At least some few trials that some people try, you know, to some those adventurous treatments, but I don't think they have proved something. You know, I don't know what have you seen at your center.
No, we don't perform TPA for central retinal vein occlusion ever, but for artery occlusion, and this is always a hot debated topic, but as you know, there was a study years ago that seemed to show some benefit to intra-arterial TPA for central artery occlusion, but then a follow-up study did not show any improvement in those patients. However, if you look at the negative studies from years ago, the authors included patients who were 12 hours out from their central retinal artery occlusion. In other words, they included patients where it would clearly not be efficacious 12 hours later. And so I think those studies shot themselves in the foot by including those patients. They did it because there simply weren't enough patients, you know, to only include patients within a few hours. But there's a nice paper out from Brown University and a few other centers that came out last year, in which they did a meta-analysis of patients. Actually, it wasn't a meta-analysis; it was their own institution, retrospective over many years, and they looked at the results of those who got TPA, and I believe it was only within 6 hours in their institution versus those who didn't. And they did report a better outcome, and I believe it was published in Stroke. So I think the jury is still out on that question. I think whenever it's done, it should be done under a trial and studied, because we still don't know, and it's certainly not standard of care even here. But I think it still needs to be studied further. Personally, I think it could be effective if performed early enough in some patients.
And there are technical issues because you have to do all the procedure to go closer to the central retinal artery, and it's like complicated doing all of that stuff. I don't think it works directly like an IV injection, but okay, you're right. I agree with you. We need more trials about that. But unfortunately, here we have very bad cases of COVID with most of them ICU prolonged a very long time. And of course, we are only seeing the sequels. We are seeing the complications of people that are 2-3 weeks at an intensive care unit, that most of the times you cannot perform a fundus exam there because of the restrictions of an ICU. So unfortunately, we are just seeing complications. Fortunately, we will be better in the future sooner. But nowadays we are still coming down. The second wave, a very bad second wave, we have a lot of cases with lots of deaths. But I hope that the sooner future we have an improvement, as you are having in the US after that massive vaccination problem that you have had. Thank you so much.
Yeah, thank you for sharing.
Yes. Sorry to interrupt you. Dr. Asmat had a case that had a 6th nerve palsy after a first dose of vaccination. And then after the second dose of vaccination had a 4th nerve palsy.
Get out of here. That is
really
wow.
Interesting.
That is really fascinating to me. So different cranial neuropathies, one after the first vaccine, one after the second. I've always been afraid to publish, if I were to see any complications of the vaccine, because I don't want to scare people away from the vaccine, because I believe in my heart that it is the source of our being saved from this pandemic. It's so important, and I don't want to give people any excuse not to get the vaccine. On the other hand, we should know about all these things. And I think that is what a fascinating case that is. I'd love to look at that with you. I mean, what an amazing, it'd be one thing if it just happened after the first vaccine, but to then have another cranial nerve after the second. I'm wondering, were they checked for a ganglioside panel, for a Miller-Fischer syndrome variant?
Doctora Asmat, ¿se le chequeó por síndrome de Miller-Fischer? ¿Tuvo algunas pruebas su paciente? Señor Manuel, si le puede abrir el micro a la doctora Asmat, por favor. Doctora Asmat. Señor Manuel, por favor, el micro de la doctora.
El micrófono está abierto, doctora.
El de la doctora Asmat está bloqueado.
No, ya está liberado.
Ya, perfecto. Doctora Asmat, ahora falta que usted abra su micro para que nos diga si ese paciente fue examinado por Miller-Fischer o si tuvo alguna otra prueba. No tenemos, no podemos, we can communicate with her, but I think I can ask her and tell you, don't worry. I have some few more questions. I don't know if you have time.
Of course.
Okay, Dolores Rivero, Dr. Dolores Rivero is asking which is the timing you would consider the damage as a direct viral cause?
Right.
There is any
Great
timing?
question. Yeah, I mean, I think in order for one to consider it being possibly directly related to the virus itself invading the nervous system, it really ought to be presenting during those 14 days in which we know patients remain potentially infectious, except in those cases of severe COVID-19 where patients are in the hospital for a long time and have ongoing PCR positivity. I mean, anytime the PCR is still positive, I think it's possible that it's direct, neural invasion by the virus. I do think, though, that most cases are due to the cytokine storm, either because the cytokine storm leads to an autoimmune response, like so many of the cases I presented today, or the cytokine storm leads to a hypercoagulable state, which leads to stroke. So I think that most of the neuro-ophthalmic and ophthalmic complications are really indirect, from hypercoagulability or inflammation, with a rare subset being direct viral invasion. But I can't prove that. And by the way, the other question is, how soon after COVID-19 can we really truly think that any condition is related even to post-infectious disease? That's hard to answer as well. We just don't know. But certainly, if you get beyond a month after someone had the virus, I start to think it's just coincidence, because enough people had the virus that they're going to have other things, But if it's within a few weeks, then at least it should be considered possibly related.
Right. Okay, I have one
You
more
really
question.
need better study.
Okay, that's right. Dr. Muro is asking if there is any relation with neuro-ophthalmology findings with attributed to a long stay in the UCI.
Oh, yeah, for sure. So many times in the ICU, patients would wake up after a long stay and we would find them to have a visual cut or a stroke of some other, stroke with other complications. And in many of those cases, we felt it was hypercoagulability from COVID-19. But, you never know. Like in my case, the patient also had atrial fibrillation. And maybe COVID-19 simply made them sick and their atrial fibrillation therefore was provoked and they had a stroke from that. In some cases, it's just hypoxic ischemic encephalopathy and, ventilation induced ischemia. They're just times when they were not, properly ventilated. And so I think it's really common in these long ICU stays to see neurological symptoms, even in patients without COVID, as we all know. Having worked in an ICU as a resident for a long time, we would see all sorts of complications, strokes after being ventilated, sometimes peripheral neuropathies and myopathies. So here too, it's hard to separate those complications that were just from being in an ICU, paralyzed or not moving, versus from the infection itself.
Thank you. Thank you, Dr. Dinking. It was wonderful. Thank you for sharing your mail. Certainly, you are going to have the answers with the cases. I hope we can see you next time.
I would love that. I feel very privileged to have been part of your conference, and I pray and wish that for the health of all of your people in the future, in the coming months, and I hope your country does well, and I hope to see you all in person one day. Thank you again. Gracias.
Thank you very much. Bye. Señor Manuel, ¿tenía usted una propaganda? Había creo que no. Pues nada, agradecer a todos por su presencia y los estaremos viendo en las próximas charlas del capítulo de Neurooftalmología dentro de un mes. Gracias a todos, hasta la próxima.